Welcome, everyone. Thank you for coming. Not that you had a choice, but so I was trying to, while I was sitting in procedure day, I was trying to think of a way to justify an EKG lecture. And well, the thing is, it is a separately billable procedure. So there you go. So my talk is called the T-Wave. Oh, I'm Trevor, by the way. I'm one of the T-Waves. Hi, Trevor. Hey. So my talk is called the T-Wave, the Rodney Dangerfield of the EKG. So for those of you who aren't familiar with Rodney Dangerfield, he was a comedian, and he was best known for his catchphrase, "No respect." And so T-Wave, in many ways, just gets no respect. And so one of our goals for this lecture is we're going to show the T-Wave some respect. For Rita up there, she reminds us that we're going to show some RESPCT, find out what it means to the T-Wave. So we're going to talk about the T-Wave in ischemia. Specifically, we're going to cover Wellens Syndrome. We're going to talk about strain patterns, persistent juvenile T waves. We're also going to talk about cerebral T waves, PE. I'm specifically not going to cover hyper or hypo-K. We had a really good EKG talk maybe 2 months back by Chris Lim, so C lecture by C Lim. That's him. I think he's asking for money. So what is the normal T wave? So the normal T wave, it has a gradual slope rising, and then it has a steeper slope as it's falling back to baseline. Isolated inversions in a couple of leads are tolerated and are completely normal. So isolated inversions in AVL, 3, V1, or V2, these can be normal, but they also can not be. And if that's cryptic, you'll see why later. Normal size of the T wave is going to be less than or equal to 10 millimeters in the precordial lead, so that's less than 1 millivolt if you're using the standard 10 millimeters per millivolt baseline on the EKG, and less than or equal to 6 millimeters on your limb leads. So that's your normal T waves. We're just going to get right into it. So this is a 45-year-old female presenting with chest pain. Anybody want to take a stab at what they're seeing on this EKG? Keeping in mind that we're talking about T waves, you don't have to go through the whole rigmarole. But what does somebody want to call out? What they think they're seeing here? So what I'm seeing,
hyperacute T waves.
Oh Jesus! Thank you. That was yes, and that's exactly what we're seeing here. So looking at the T waves in this EKG, we're seeing in the inferior leads as well as in V4, V5, V6 T waves that are, if not meeting those millimeter criteria for being extra large, they're quite a bit larger than their counterpart QRS in each lead. And so when you're thinking about T waves, I want you to think about them in relation to the QRS in that lead. So this patient actually had a STEMI, went on to develop a STEMI, and these are examples of hyperacute T waves. All right, so this is some guy with chest pain. That's all the history you have. Anybody want to give a shout out? And just kind of this is a little bit of a maybe a basic lecture for a lot of people, but I think we do cover kind of a good breadth. There'll be some cool stuff later on too. But so anybody want to take a stab at what they're seeing here? This guy with chest pain. So again, we're seeing pretty large T waves here in the precordial leads, and actually what we're also seeing, especially in V3 and V4, maybe a little bit in V5, is ST depression. And so what this is this is De Winter T waves, and De Winter T waves are a STEMI equivalent. So this would be something you'd want to activate the cath lab for, typically an LAD occlusion. All right, this is a little more subtle, and it kind of begs the question: is an inverted T wave in AVL normal? And so this is a patient presenting with chest pain. Swills, what do you think? Is this just benign AVL T wave inversion, and this patient can go home, or is there something concerning? you're seeing?
Maybe ours a little, not really. Maybe the lateral leads are concerned. So I would say probably not just from.
Yeah, and I think it's a great interpretation. I think you're picking up on these. So part of what you're seeing is you do see the inverted AVL, and maybe that's normal, but what we're also seeing is actually looking at those T waves in 2, 3, and AVF, they are pretty big compared to their QRSs, right? I mean, the AVF, you could actually fit the QRS inside that T wave. A little bit same with 2. And then you're seeing if AVL is the reciprocal of the inferior leads along with V5 and V6, we're actually seeing some ST depressions here as well. So this is a very subtle but pretty concerning EKG for inferior STEMI. So Amal has a nice talk that Olu showed me where he goes through all these EKGs that just have isolated AVL inversion. And I want you to think about AVL inversion as the reciprocal of the STEMI in the inferior leads. It might be the first thing that shows up. Apparently, if you go into the cath lab and you occlude someone's right coronary artery just for shits and giggles, the first thing that happens is the T wave in AVL will invert even before you see hyperacute T waves in the inferior leads. It's a very sensitive marker of inferior STEMI.
Especially because L is the most lateral lead. So if you're having something that's really very lateral, you may only see it in L.
Yeah, that's a great point.
Marriott points that out in his book and in his lectures a lot, that you should always look at L.
Yeah, so what Dr. G is saying for the people on Zoom is that AVL is the most lateral lead, so it will be the most sensitive in reflecting changes in the inferior leads. So moving along, this is a 28-year-old with anxiety and chest pain, and for the sake of brevity, I'm going to leave the crowd alone. So this is actually a pattern that, I think it's easy to be concerned when you look at this EKG, right? This patient clearly has these symmetric inversions in V2 and V3 and V1 as well, but obviously that can be just normal. But so this patient is 28-year-old, I mean, do I have to worry about a PE in this person, right? They have T-wave inversions in their cordial leads. But so this is a pattern that I think we should be familiar with, especially given our patient population. This is persistent juvenile T waves. And so we see this pattern very frequently in young women, especially of Afro-Caribbean descent. Whether the persistence of it, really, if these T waves persist from youth until 30, 40 years old, is kind of debatable. There is some evidence that the T waves can actually develop over time or become less apparent over time. So persistent may be a misnomer, but the pattern is one of symmetric T wave inversions in the cordial leads. Now, why don't I have to worry about PE in this patient? Well, hopefully you did a history and got a sense of if they have risk factors, but also looking at this EKG, there's no sinus tachycardia. There's no real inversions in the inferior leads of the T waves, which would be more concerning for kind of right heart strain. There's also, obviously, not nearly sensitive or at all, but there's no S1Q3, T3. So for those reasons, along with the whole clinical picture, this EKG is consistent with persistent juvenile T waves. And so it is a pattern we should recognize. So this is a schematic I shamelessly pilfered from Steve Smith's EKG blog. I didn't even give him credit, so I'm sorry, Steve Smith. But so I love this schematic because I think it explains one thing. I don't want to go through the whole thing. I think we all have a good sense of progression of acute coronary occlusion, but I do want to point out when you look at if reperfusion is established at any of these time points, be it with PCI or with spontaneous opening of an occluded vessel, the first thing you're going to see is this terminal T wave inversion. And what does that look like to everybody? Either this terminal T wave inversion or this late terminal T wave inversion. That pattern there. If I said I didn't think of that. But what I wanted was Wellens, and so I think it really illustrates the pattern that you're looking for with Wellens, especially when you marry it to the clinical presentation, where these patients become chest pain free, often spontaneously, as is the case for Wellens syndrome. So, so kind of moving along and just keeping that in mind, that this is the natural course of reperfusion, this is the natural course of the changes on the EKG we see. So what about Wellens syndrome? So, looking at this EKG, I think that anyone would call these Wellens waves, right? No one's going to look at this EKG and say, oh, those aren't Wellens waves. Well, these are clearly biphasic, kind of deeply inverted T waves here. And so when we talk about T waves, just kind of nomenclature is that the T wave is inverted if its terminal portion is negative. So these are inverted, but also biphasic, the terminal portion negative T waves. This is a patient who had this is 24 hours after a successful stent placement. And so I think it illustrates how important it is to keep in mind the clinical context, and that Wellens waves are just a marker of reperfusion. So that's what I wanted to illustrate with this EKG. What about this EKG? Is this Wellens syndrome? I'm just pausing for dramatic effect. I don't want anyone to answer. So, looking at this EKG, there's definitely inversion in the terminal portion of the T wave in V3, V4, inverted T wave in V5. But Borat would say not, right? Because this isn't the reason this isn't Wellens syndrome is because there's LVH on this EKG. And so you can't diagnose Wellens syndrome in a couple of different contexts. One is if you have poor R wave progression in the precordial leads. Another is if you have Q waves in the precordial leads. Both of those preclude the ability to diagnose Wellens. Reason being, you're going to have repolarization abnormalities as a result. Also in the case of LVH. Now you might be looking at this EKG saying, well, where's the LVH? I mean, if I look at V1 and then I add V5 or V6, it definitely doesn't meet the Sokolow-Lyon criteria. But there's actually, so this is LVH, this is actually pseudo-Wellens. And so the reason there's LVH is there's this criteria that's a little bit more sensitive and specific for LVH called the Peguero-Lopresti criteria. So you take the S in V4, you add it to the S in the deepest S you have in any lead. And if it's greater than or equal to 2.3 millivolts in women or greater than or equal to 2.8 millivolts in a male patient, that is pretty sensitive and specific for LVH. So it operates a little bit better than the other criteria that we have for diagnosing LVH. This is not a lecture on LVH, it just explains the EKG and why this is pseudo-Wellens and not Wellens. This patient actually had cath lab activation and had clean coronaries, or no culprit lesion. So true Wellens is, again, you see your Wellens waves. Typically, it's going to happen. A patient has chest pain. They spontaneously establish reperfusion, and they're chest pain free, and that's when you see the Wellens pattern. Again, because it is a reperfusion type of pattern. Patients with Wellens, they don't need emergent cath, but they need urgent cath, right? They have established flow to the artery distal to the myocardium behind the artery, but they'll need a cath in the next couple of days. So, it's at your discretion, obviously, if you activate the cath lab for someone, especially when you have a concerning EKG and a concerning story, but just know that typically these patients can get admitted and then in a day or two get their cath non-emergently.
What you don't want to do is let someone that you really suspect a Wellens on, you don't want them to have a stress test.
Yeah.
But they can die in the stress test doing it. And they should have a cath, like you said, they don't have to have it that minute like a STEMI, but they should not be discharged from the ED. They should be admitted and get the workup in the house and not a stress test.
Yeah, so Dr. G makes the point that these patients should not be stressed as they can die during the stress test. That's definitely so. Admission is appropriate for these patients, and they do need urgent cath. No. Okay, so inverted T waves, looking at the literature, they talk about T waves being inverted for primary or secondary reasons. I don't really find that, I don't find it all that helpful to think about T waves in this way. Primary T waves, they talk about being secondary to ischemia or injury, and secondary T waves are due to abnormal ventricular excitation. So it's secondary to the abnormal depolarization. I mean, I think if a T wave is inverted, you should think about why it's inverted, and primary, secondary, it's not so helpful. But I really like this schematic because I've never been able to really think through why we see a strain pattern on EKGs. And so what you notice in the normal LV, so normally you have a depolarization that goes from endo to epicardium. And as that depolarization wave approaches the electrode, you get a positive deflection on the EKG. Likewise, repolarization goes from epi to endocardium away from the electrode. And so you have a repolarization wave leaving the electrode sensor, so you get a positive deflection as well. But with a hypertrophied myocardium, there's so much time for the depolarization wave to progress from endo to epicardium that the repolarization front actually occurs behind it. So now you have a repolarization wave traveling towards an electrode, and that's going to give you a negative deflection on the EKG. And I think it's a really great illustration. This is from Martingale, her textbook on EKGs. I stole it, and I didn't give her credit, but I'm giving her credit now. So this EKG illustrates the strain pattern really well. We have, pretty deep S waves, just kind of looks like left ventricular hypertrophy just from the magnitude of the S waves in the precordial leads. But we also do see these kind of strain waves in one AVL V5, V6, these sloped inverted T waves in those leads that are classic for kind of the strain pattern. And so I think this EKG just does a really good job of illustrating that point. This is a really interesting, these are two EKGs together that I think are really interesting. So this is a 64-year-old female, epigastric pain. She has a stent but doesn't know where it is. And this is her initial EKG. So let's say this is EMS brings you this EKG. And looking at it, she has inverted T waves, V4, V5, V6, also in the inferior leads as well, 2, 3, and AVF. So she has pretty diffuse T wave conversions. Nothing real concerning for acute coronary occlusion, but she's sitting in your ED and she starts complaining of chest pain again, and this is the EKG you see. So now, without EMS's EKG, I think it might be easy to gloss over this EKG and say, well, she's having chest pain, but everything's upright. Look at the T waves are all upright and all these leads. Maybe I don't have to be so concerned. So comparing EKGs, especially over time, obviously it's super important. I think significantly so in this case. And actually, looking more closely, if you were to have the story of, or the EKG prior, having all these T wave inversions, looking at V1 especially, this T wave is pretty tall, and it's taller than the T wave in V6. And this is actually also kind of a STEMI equivalent, the too tall T wave in V1. So taking that along with all of these T wave inversions in the inferior and lateral leads, this patient went to cath lab, actually had a 100% RCA stent thrombosis. And so this is how she presented. So this is a good example of pseudo-normalization of T waves, having initially negative and then upright looking normal T waves as your change reflective of ischemia. This EKG, 48-year-old male, smells of alcohol found down. He was outside the liquor store. EMS picked him up because that's what they do. No offense to our EMS providers. So let's say this patient was parked in 17 hallway and for unknown reasons got an EKG. Anybody want to shout out what they're seeing or give an interpretation? Lisa, what do you see? So Lisa's jumping the gun. She said cerebral T waves. But she's completely right. They're cerebral T waves. And so what cerebral T waves are deep symmetric T wave inversions, specifically in the precordial leads. These are actually pretty, when you see them, they can be a lot deeper, a lot more broad-based, and much larger. And they tend to be the largest T waves that you'll see on an EKG. So these are definitely cerebral T waves. This patient probably has some kind of acute intracranial process going on. It's typically subarachnoid hemorrhage that will produce cerebral T waves. They think that it's due to like a localized myocardial catecholamine surge, but I don't even know really what that means, but that's what I read. And so I'm saying it to all of you. Oh God. All right, well, this one we can go through quickly, but so looking at this EKG, what we see is, again, we see T wave inversions in the precordial leads. And right away, I don't have any patient information here, but if it is, let's say it's a young female, similar to our persistent juvenile T wave pattern. The other things that are concerning on this EKG, though, for PE, and make it more concerning than the prior EKG showing persistent juvenile T waves are, we do have inversion in our T wave in lead 3, not so much in AVF or 2. We actually also see our S1. Q3 pattern, maybe not so much Q3, maybe just T3. So, but also very importantly is in terms of RV strain, we are seeing a little tiny bit of ST elevation in V1 as well. Very subtle, but it is there. So this patient actually had bilateral PEs, and this was their EKG. So, in summary, show some respect for the T wave. Check prior EKGs. Always look at the EMS EKGs. Again, you don't want to miss pseudonormalization. T waves, they are the canary in the coal mine for acute occlusional MI. And that's a canary, and that's the coal miner. So this canary's like, oh, it's arteries occluding. And the coal miner's like, oh, I better call the cardiologist. And don't be fooled by secondary T wave inversions. There's lots of reasons that you can have inverted T waves secondarily, but I think keeping a low threshold for if someone has a concerning story and you see abnormal findings on an EKG, know that there are mimics, know that there are reasons for someone to have inverted T waves or a Wellens pattern, but you keep your clinical suspicion high. And that's my dog. Not taking any questions.
Okay, comments.
Great job.
There was a question on Zoom. One of the attendings on Zoom answered it, but figured out shared the question. The question was, if you're in a community center and you have a Wellens, is that someone you need to anticoagulate or thrombolize, or do they need to just antiplatelet? The answer was by the attending that the literature says you can treat them like an NSTEMI and antiplatelet, but if they get symptomatic again, you may want to repeat the EKG, or if a transfer center recommends thrombolysis, then does anyone have comments on that?
I agree. I would just anticoagulate